Hello everybody, I'm Alan Meyer. I want to start by saying thank you to Marcus, Darren, Linda, and April for organizing this workshop on extreme context. Well, over the last 35 years, I've been studying natural experiments that were created by environmental jolts. The first jolt was a doctor's strike in San Francisco, then came the deregulation of savings and loans and electric utilities. The next one was the popping of the dot-com bubble, but most recently, April Wright, Trish Ray, John Staggs, and I have been studying the impact of an Ebola outbreak in a hospital emergency room. I'd like to address three topics in this talk. First, some lessons from the study that we did on Ebola. Secondly, some suggestions about how to design research that can stand up to these kinds of contexts. And third, a few preliminary thoughts about where to find theories that will handle extreme conditions. So last March, the four of us published a paper about Ebola's impact on a hospital's emergency department. We argued that this is a specific instance of the disruption of what we call places of social inclusion. So let me explain what a place of social inclusion is. A public library, a schoolhouse, a sanctuary city, an emergency room. These are four instances of places of social inclusion. These places are critical to the functioning of liberal democracies. As a society, this is where we try to come to grips with grand challenges. And, as individuals, this is where you want to go if you're bleeding or broke or hungry or homeless. They have three defining characteristics. First, they are places, that is, they're geographic locations. So if it doesn't have a set of GIS coordinates, it's not a place of social inclusion. Secondly, they're inclusive places. All citizens are welcome to enter, to make claims for access to the resources and the services they provide. And third, they are precarious. They're precarious because they deal with wicked problems, they do it with scarce resources, and they inevitably seem to become flashpoints for political and ideological contention. Well, the setting for our study was the emergency department in a large metropolitan hospital in Australia. In the interest of time, I hope you'll let me stipulate that for theoretical foundations, we turned to the literature on the sociology of place, humanistic geography, and the institutional work literature. We used multiple methods. We took a grounded theory approach to do brief ethnographies based on 210 hours of observation in the emergency department. We audio taped 91 interviews with doctors and nurses and hospital executives. And while we were doing all this data collection, though, in Australia, up in West Africa, a bat infected an 18-month-old boy with Ebola. In August of 2014, the World Health Organization declared a public health emergency, and then the Australian government designated our field site as one of the nation's Ebola response and treatment hospitals. Since we were already ensconced in the emergency department, we had front row seats for observing the epidemic's impact on healthcare workers, physically, socially, psychologically. Now, before I tell you what happened, let me set the stage a little bit. It's important to understand that the emergency room was already the world's most dangerous professional workplace. People that work there get non-fatal violence-related injuries at many times the rates of other occupations. The police do get more fatalities, but the ED folks, they get more violent injuries. And if you think about it, it makes sense. The emergency department staff is routinely exposed to infectious diseases. They deal with violent and volatile people every day, patients with the dementia, discombobulated drug users, panic-stricken accident victims, and what some of our informants said was scariest of all, the hysterical parents of sick children. And they do this all with incredible equanimity. They've come up with an awesome set of techniques for de-escalating conflict. They have an array of risk mitigation routines and technologies that they can turn to. But their most potent defense against the slings and arrows of the emergency department is that they have been conditioned to experience and to express powerful moral emotions like pride, honor, compassion, empathy, and so forth. When the Ebola designation was announced, that triggered mayhem. And basically the specter of Ebola sparked acute fears among the team. The fears that overwhelmed and sometimes extinguished the moral emotions that they usually operated under, propelled these people from a world of risk into uncertainty, led to fragmentation of the team, triggered acrimonious dissension among members, and essentially ushered in what Carl Weick calls a cosmology episode. Carl said that this produces a sudden and overwhelming feeling that the universe is no longer a rational, orderly system. Now, I'm recording this in early October, and as of today, I'd say that we all are about 7 months into a global cosmology episode. The COVID pandemic has crashed our economies, it's filled up our hospitals, it's emptied out our public spaces, closed down schools, grounded airplanes, and I don't know about you, but the shock waves just seem to keep ripping through my life every day. So, what are the implications that our Ebola study might have for COVID? When I'm talking to frontline workers, healthcare workers, I say, look, the COVID pandemic is likely to catapult you from decision-making in the face of risks with which you're familiar into decision-making under extreme uncertainty. You need to get ready for the sudden upwelling of basic emotions, fear, anger, grief, disgust, not only within yourself, but also throughout the team. You need to know that these emotions are likely to overwhelm the moral emotions that originally drew you to caregiving or teaching or research. You should expect role conflicts to shatter the cohesion of your team and to break it up into contending factions. In our emergency department, we saw a remarkable transformation. Before Ebola was designated, we saw healthcare delivery teams that for the most part were cohesive, congenial, and coordinated. After, at least particularly when they were discussing Ebola, they became fearful, edgy, contentious. It was as though a team of professionals had disintegrated and turned into a gaggle of parents that were worried about their kids, spouses worried about partners, adult children of elderly parents who realized that their underlying conditions put them at risk. One doctor said, "I'm terrified. This is not what I signed up for." But his colleague, somebody that still clung to a few moral emotions, said, "What are you saying? This is exactly what we're here for. Don't you get that?" It was an incredible transformation. When I'm talking not to caregivers, but to managers or policymakers, I say, please, the most important thing is to recognize that your place of social inclusion is one of the cornerstones of our civil society. One lesson that we've all learned from COVID is that pandemics can lay bare society's inequalities, they can open up racial fault lines, they can bring market failures to the fore, and when these kinds of things happen, they thrust places of social inclusion into even more critical roles, and they make them even more precarious than they were before. So, maintaining them becomes both harder and more important. All right, frontline workers, they need reliable information to absorb uncertainty. Uncertainty absorption is what helps you move back to decision-making under risk and restore some of the calm. They're going to be your subordinates are going to be developing new, or your first-line workers are going to be developing new risk mitigation practices. They are best developed in the trenches, but your job is to help codify them and make sure that they get disseminated throughout the team and maybe throughout the organization or across society. But probably your most important and least recognized role is that you need to be a cheerleader. You need to encourage and celebrate the moral emotions that they began with. Our study shows that this is the best hope for tamping down the anxiety and rebuilding the cohesion in these teams. All right, so what does this mean for designing research? Well, rule number one is be ready to drop your tools. This is a lesson that I learned while I was wrapping up my dissertation, so if you will, let me quickly take a stroll down memory lane. It was May 1st, 1975. I was in the home stretch of data collection for a dissertation being done in a sample of hospitals in San Francisco when, with almost no warning, all the hospitals got a severe jolt from their environment. Argonaut Insurance Company had summarily canceled the group malpractice insurance of 4,000 doctors and then offered to reinsure them as individuals at a 384% rate increase. This triggered a doctor's strike that went on for a month, for 30 days. My first thought was, thank God I finished collecting my dissertation data. This would have really messed me up. But a second thought was, this is like a natural experiment. I've been in these hospitals for over a year now. I've got baseline data. I've got theory that I can use to predict their adaptive responses. So all I have to do is go back out in the field and scoop up some more data on their responses and the outcomes, and I'll have a really nifty study. So I drafted a questionnaire. Figured it'd probably be a good idea to run it past my committee, so I asked Jeff Pfeffer and Bob Biller if they could meet with me. We got together. I handed him my questionnaire. I said, "How does this look?" And I'll never forget what happened. They sat there. They read the questionnaire. They looked at each other. Jeff started shaking his head very slowly. Bob said, "Well, let's say you were to mail this out to hospital administrators tomorrow. I think you'd be about as likely to get back valid data as if you'd sent a questionnaire to the Romanovs during the Bolshevik Revolution and said, 'What just happened here?'" So I had the sense to drop that tool. I threw away my questionnaire. I selected 3 hospitals that were maximally different, and instead of doing interviews or writing questionnaires or digging up archival data, I hung out in cafeterias. I struck up conversations with docs and nurses and administrators who were on breaks. One of the best things I discovered was to stand in a line at the cafeteria, and people were forced to stay there, and they couldn't. They had no choice but to talk to you. I did this for 3 weeks. I spent the morning in one hospital, the afternoon in another. The next morning, I switched to a new set of hospitals. And I won't go on to say what I did, because the important thing is I dropped my tools, and by doing that, it led to the best paper that came out of my dissertation. So the first rule is to drop your tools. The second rule is to get out in the field immediately, because the initial impacts of a jolt and the initial responses of people and organizations provides really rich data that's best observed in real time. When you do this, you're going to undergo a shift from explaining variance. You're going to stop worried about your R squared, and you're going to be focusing on understanding the process. You'll be gathering more observational and more qualitative data. You'll be switching to more longitudinal and temporally sensitive methods. You'll be paying attention to unfolding events instead of trying to verify static relationships. A third suggestion is to raise your level of analysis. I've found that you can't understand a social system that's in flux unless you conceptualize and study it at multiple levels. So if you've been looking at individuals, time to think about individuals in teams. If you've been studying organizations, you want to reboot and study organizations that are embedded in organizational fields, forming interorganizational relationships, and so forth. A fourth suggestion is to narrow your field of observation, because otherwise you'll be overwhelmed. I've found in a couple of cases a good way to do this is with theoretical sampling, to select some exemplars, to study them intensely, and to understand them before you go back to more systematic or more qualitative or more quantitative techniques. A final rule that's kind of an overarching one, I think, is to go ahead and treat your research design as a prototype. As doctoral students, we were all trained to think of them as more like constitutions. Very difficult to change them. Something never should be done in the field. But instead, extreme contexts suggest that it's better to think of them as licenses that are subject to renewal. So in selecting units of analysis, variables, samples, even theories, you should prefer choices that are temporary over ones that are permanent. You should make moves that are correctable, not correct. You should look for theories that are discoverable instead of theories that you already know. Okay, so how do we find theories that have enough resilience to hold up? My first thought would be to jettison equilibrium. I would say that about 95% of organizational science is actually the science of organizing at equilibrium. I think theories are riddled with assumptions of equilibrium and equilibrium seeking, but extreme contexts create flux and upheaval that don't hold up under equilibrium assumptions. So get rid of them. General linear reality, that is Andy Abbott's term for deeply held causal beliefs that treat linear models as though they were representations of the actual social world. So mathematical assumptions that we adopted for analytical reasons have morphed insidiously into ontological and metaphysical assumptions about how the world works. So instead, you might think about substituting nonlinear concepts and mechanisms. Ideas like complex dynamical systems, self-organization, coevolution, network formation, autocatalytic feedback loops, and if you're looking for causal mechanisms, you might turn to things like exaptation, effectuation, and emergence. And you should brace for cosmology episodes. You should know that you're going to see them in the field, and you're very likely going to experience them yourself. And, let me break in and just on a personal note, I'd like to offer heartfelt thanks to the doctors and nurses and patients that invited our research team into their place of social inclusion. I know that sharing their Ebola-induced cosmology episode has helped me personally to cope with the disruption that I've seen in COVID. And I'll tell you this, the emergency department of a public hospital is a great place to find people who are modeling courageous and moral behavior. It's inspiring and it's reassuring, and it comes at a time when obviously we really need this. Because all around the world, places of social inclusion are morphing into extreme contexts. Sanctuary cities is a prime example. Moral emotions are overwhelmed by basic emotions, political and ideological conflict erupts, and I just think it's incredibly important for us as social scientists to try to understand how places of social inclusion can be protected and maintained. Nowhere is this more apparent than at polling places in the United States of America in 2020. For democracies, polling places are the quintessential places of social inclusion. This is where we keep our voting booths and our ballot boxes, but in the U.S. they've become the epicenter of sort of a dystopian cosmology episode. Due to the combination of the COVID pandemic and a president who's an ignorant narcissist, they've turned our polling places into political and ideological danger zones. I'm sorry to end on a somber note, but I'm out of time, I'm sure. That's my take on organizing in extreme contexts. Thank you very much for listening. If anyone would like to learn more about our findings, here are hyperlinks to a couple of papers and a blog that report and translate our research. So, thanks again for listening, and I really look forward to our conversation on October 28th.